Even when they're given properly, over 15% of standard mandibular blocks fail, often because of a variation in the normal anatomy. In 1973, Dr. George Gow-Gates, a general practitioner of dentistry in Australia, described a new approach to mandibular anesthesia. His technique, which he'd been using in his practice for about 30 years, is a true mandibular nerve block. It is indicated when we are carrying out procedures on either one or multiple mandibular teeth in one quadrant, as well as for procedures on the lingual soft tissue or the buccal soft tissue anterior to the first molar. For surgery on the molars, a separate buccal nerve block may be required. It is particularly indicated if there is a history of failure of the standard mandibular block and evidence of accessory innervation. The nerves anesthetized with the Gow-Gates technique include the inferior alveolar, mylohyoid, lingual, and auriculotemporal nerves. The same tissues are anesthetized as with the standard block, except that about 75% of the time the buccal nerve is also anesthetized, eliminating the need for a separate buccal injection. The objective of the Gow-Gates technique is to deposit local anesthetic immediately anterior to the neck of the condyle. This is in close proximity to the mandibular branch of the trigeminal nerve after its exit from foramen ovale. With the Gow-Gates technique, we should be able to anesthetize all of the sensory branches of this nerve, including any accessory nerves. You begin again by palpating the anterior border of the ramus. You do move superiorly to feel the coronoid process and the insertion of the tendons of temporalis. This will outline your lateral landmark for insertion of the needle. The needle will be advanced superiorly and laterally, advancing towards the neck of the condyle until you contact bone, withdraw slightly, aspirate, and inject. The patient should open her mouth wide, and you're lining up the plane from the corner of the mouth to the intertracheal notch, which is that part of the ear just below the tragus. And this gives the correct angle that the syringe will take when you're going intraorally. It is also helpful to look at the angle that the tragus makes with the face, as that also will help with the orientation of the syringe intraorally. Once the angle is determined, you are then able to begin the injection by palpating your intraoral landmarks. And as with all three techniques, you start off by feeling the anterior border of the ramus. My finger is now in the coronoid notch and external oblique ridge, and I move it upwards superiorly until I feel the coronoid process. And at this point, I can feel the insertion of the temporalis muscle. It's important to not insert the needle within muscle, so this acts as a lateral guide for the insertion of the needle point. The needle insertion is higher and more lateral for the Gow-Gates block compared to the inferior alveolar nerve block. The height is determined by the maxillary occlusal plane, and very often the needle will lie just below the mesiopalatal cusp of the second molar. So the needle will be coming at the height of the maxillary occlusal plane. And the lateral landmark is determined by the tendon of temporalis. Again, you do not want to insert into the temporalis, so you insert the needle just medial to that landmark. And this would represent the correct insertion point for the Gow-Gates injection.